Hello and welcome, everyone. It's amazing to be back here with all of you once again. I hope you had a nice weekend and are ready to find out a bit more on our patient success stories. And tonight we do have another special guest with us. Dr. Garcia is with us. Dr. Laura Garcia is with us. Thank you so much for joining us again. And how are you? It's been a while since you've been here with us last time.
Yeah, how are you doing? Thanks for this evening.
We are very happy to have you back. Okay, so tonight, of course, Dr. Garcia will talk about recurrent miscarriages, and she has prepared an amazing presentation with some amazing cases you can see for yourself, of course. And let me just mention that tonight, of course, Dr. Garcia is with us. We have a little bit of a problem with the camera, but I can assure you she's right. She is definitely Dr. Garcia. And if you had a chance before to see her with us, because this is not the first webinar with Dr. Garcia, so I'm always happy to have you on board with us, of course. And let me just also add that, remember, we will start with the presentation, but afterwards, as always, it will be time for your questions. You can put them in the chat section during the presentation or afterwards. And I'm sure Dr. Laura will be happy to help you out with any questions that you might have. And I'm already looking forward to hear what Dr. Laura has prepared, of course, for all of us. And also let me add that my IVF Fences is a part of European Fertility Society, and we are very proud to be bringing those topics. As you know, this autumn series is all about success stories. We definitely want to bring the cases, the real cases, and I guess that will be it from me at this point. And Dr. Garcia, are you ready to discuss our topic tonight? Dr. Garcia, can you hear me? Just to clarify.
Yeah,
Okay,
perfectly.
Excellent. So thank you so much, and let's go ahead with our topic tonight, okay?
Okay.
Thank you.
So this presentation is about recurrent miscarriage, how to succeed, and it's based on a clinical case of one of my patients. So I will follow all this presentation, talking in particular about that case. But of course, I will be informing a little bit in deep about all general aspects that could be involved in repeated miscarriages. So what will we cover? We will talk about definition of recurrent miscarriages, and then we will go ahead with this clinical case and review general description and situation, diagnostics, protocols and procedures, embryo transfer, resume of pregnancy, and conclusion. So what is recurrent miscarriage? Regarding Eshre Society, recurrent pregnancy loss is defined as the loss of 2 or more pregnancies, excluding ectopics and molar pregnancy, and it is necessary to be before 20 weeks of gestation. So I will introduce this case. It was a couple. The female was 34 years and had 54 kilos, 162 centimeters, no previous unsuccessful IVF, but she had 3 miscarriages after natural pregnancy with the same couple. No familial backgrounds, no diseases, no medications, and normal BMI. The male was 37 years old, no familial backgrounds, no diseases, no medications, so again, no problem at all. What were the diagnostics that we were reviewing? So for the female, it's always necessary to study ovarian reserve, also karyotype testing, also exclude uterine malformations. Also, it's necessary to be sure if there is endometritis, that could be the problem, coagulation disorders, and immunological disorders. For the female, it's very important to study the general spermiogram parameters and see if it's necessary to do FISH tests, which is genetic tests in the spermiogram, and fragmentation to see if there is fragmentation in the DNA brain, and of course karyotype. For the male diagnostic, everything was normal, so normal spermiogram in our clinic with good volume, good concentration, good mobility, no problems with morphology, and karyotype was 46XY. For the female, we started studying ovarian reserve, and it was pretty normal. She had 1.8 for AMH, and she had 10 antral follicle count. So it was pretty normal ovarian reserve. By contrast, the karyotype revealed that she had translocation reversorion between chromosome 13 and 15. So in this couple in particular, that was the problem. Nevertheless, it's also necessary to study ultrasound and see there are no uterine malformations that could be the cause, such as septums or fibroids, and no hydrosalpinx. Also, we did a deep coagulation testing, including thrombophilia, antiphospholipid syndrome, and everything was negative. And for immunological disorders as well, we excluded celiac disease. We did KIR testing that was normal. Natural killer cells was in the normal range, and she had good vitamin D and no problem with glucose insulin metabolism or thyroid. So you need to remember it is extremely important to do a karyotype for both partners. And of course, even if there are no miscarriages, we always recommend to do karyotype before going ahead with IVF. So what is karyotype? It is a blood test that confirms the number of chromosomes. So humans, we have 23 pairs of chromosomes, and we have the structures that confirms that we are normally chromosomally or not. So in that female in particular, there was a structural problem. What was the problem in particular? With this chromosome 13 and 15, she had a fusion. So instead of having 46 chromosomes, she only had 45 because an arm of chromosome 15 was fusionated with chromosome 13. So people having translocation, reversorion translocation, has no phenotypical problems, so everything is healthy for them. By contrast, they can have problems with reproduction, they can have more risk of miscarriage and less possibility of pregnancy. So again, translocation occurs when the chromosome is joined with another chromosome. For reversorion translocations, it is usually involving 13 chromosome, 14, 15, 21, and 22. And generally speaking, the possibility to find euploid embryos for people having translocation, it is less likely. So generally speaking, it's 33% of euploid embryo. But when the translocation is in the female, the possibility is still less. So it is 18% of probability of normal embryo. So what we offered to that couple, we did IVF plus ICSI with a PGT with SR to exclude problems in chromosomes in embryos having structural abnormalities. So what is an IVF-ICSI? It is a procedure to inject directly sperm to each egg. We are always doing ICSI when we need to do genetic screening or genetic SR, PGT SR. Of course, it is possible to do it with traditional IVF, but it is recommended to do with ICSI procedure. So we use a micropipette and a holding needle to do all this in our laboratory. And of course, microinjector is necessary for biologists, and we always prepare eggs the day of the egg retrieval, and we prepare sperm. Here we have the general IVF step by step. So you can see when we have period, we always confirm with our patient in the basal ultrasound, in the initial ultrasound, if everything is okay to start with injections and do the ovarian stimulation. 5 to 6 days later, we do ultrasound number 1, and then every 48 hours we do ultrasound 2, ultrasound 3 to check the development of the follicles. Then we do the egg retrieval. This is called day 0, and it's the same day we ask the male sperm. In a traditional IVF, we leave all these embryos from day 0 to day 5, and we do the embryo transfer. And 11 days later, we do the pregnancy test. By contrast, when we need to do PGT, we don't do the embryo transfer in this fresh cycle. And by contrast, we do the biopsy of the embryos, and embryos remain frozen. And it's only once we have received the testing of these embryos that we will organize a call with our patients to explain the genetic results, and we will prepare endometrium before embryo transfer. For that couple in particular, for that female, she had a low possibility to find at least one embryo with one only cycle. So we recommended sorry, we recommended to do the double stimulation. And what is that? In the same month, we are able to stimulate twice this female. In the first round, we do the egg retrieval, and 5 days later or 4 days later, we start again with another stimulation. And then we do 2 weeks later a second egg retrieval. And why we recommended that to this couple? Because she was only having 18% of possibilities of normal embryos. So that's the reason why we recommended to do the double of the possibility to create embryos. So what we did was IVF cycle with ovarian stimulation, and we did the biopsy of the blastocysts, and every single embryo we study when it's really creating the blastocysts, and we're doing day 5 or day 6 biopsy prior to transfer. Of course, it increases the chances of having a healthy baby because it is offering the possibility to reduce the risk of miscarriage, to increase the probability of pregnancy per transfer, and of course, we reduce the duration of treatment and the number of cycles. You can see in this screen that PGT is the general pre-genetic testing for embryos. So PGT-A refers for aneuploidy. So it's people having likely of problems in chromosomes such as maternal age or previous IVF failures that we will do PGT-A to study in deep for every single embryo the chromosomes. In the other hand, we have PGT-SRs for structural anomalies. That this is the test that we did for our couple, and it detects alterations in the structures. So not only the number of chromosomes, but also to see if there is translocations. And PGT-M, it's for couple having risk to transmit any disease to their babies. So in our couple, we achieved in the first round 3 blastocysts, and in the second round 5 blastocysts, so a total of 8. These 8 embryos were biopsied and sent to the genetics laboratory, and the PGT-SR results reveal only 1 embryo was transferable, euploid without translocation. So of course, with 34 years old, it's not that situation, it's only because she had this translocation. So what is euploid embryo? Euploid embryo is containing the 23 pairs of chromosomes and having not a risk of miscarriage, whereas an euploid embryo, it's embryo having gain or loss of genetical material, problems with chromosomes that could lead to miscarriage or to babies born with chromosomes disorders such as Down syndrome. So in that couple, as long as they achieved to implant and they had 3 pregnancies, we recommended once the embryo was confirmed that was normal, we did natural cycle for endometrium preparation. So we monitor ovulation, and when the endometrium was more than 7 millimeters and the follicle in the ovary was more than 16 millimeters, we did a trigger of ovulation and the embryo transfer 7 days later to reproduce the window of implantation as she had in the natural cycle. Then we did support of luteal phase with progesterone 400 milligrams every 12 hours. And of course, we did the embryo transfer with the abdominal scan monitoring. And 11 days later, we did the pregnancy test. So fortunately, we had an ongoing pregnancy with no complications, where it was no necessary to do invasive tests as long as we had transfer an euploid embryo. The pregnancy ended at 40.3 weeks, and the weight of the baby was completely normal, 3 kilos, 230 grams. Vaginal delivery, so everything was great. As conclusions of this case, we can inform you that it is very important to study all possible causes when repeated miscarriages. And we need to remember it could be more than one problem. And even if karyotype is normal, PGS in miscarriages, it is recommended to only focus on normal embryos. And when we found translocation, it is necessary to talk with our couple, with our patients, to explain the possible percentage of normal embryo that we can find. So thanks a lot for your time. I hope you find interesting this case, and I'm happy to answer all your questions.
Thank you so much indeed, Dr. Garcia. It's always good to look at this case, most cases, and thank you so much for explaining this, all the details. And of course, right now it's time for your questions. So your favorite part right now, it's all up to you. You can ask anything that you want, and of course, Dr. Laura will try to help you out, right? Let's have a look at the very first question. So, good evening. My issue is linked to mild adenomyosis and uterus inflammation, but no infection found after 5 miscarriages, early miscarriages, sorry. I'm 37, normal karyotype and chromosomes okay, AMH of around 4 nanograms per millimeter, normal sperm. Can IVF fail with issues of general inflammation of the uterus? Can prednisone or an antibiotic be used during IVF cycle or any other treatment? Thank you for your first question.
Sorry, Caroline.
It's okay, of course. We have time, don't worry.
Okay, so thanks for your question. Adenomyosis, it's a very severe. So sorry, I need to drink water. Hang on a second.
Sure, take your time. No problem at all. Let's give a minute to Dr. Garcia so she can have her voice back, okay? And of course, we will be able to continue. And in the meantime, of course, you can put all the questions in the chat so we can help you out with those. There are some of the questions ready right here as well. So thanks a lot for being active and taking part in it, of course, as well.
So sorry, Caroline. Can you hear me?
Yes, we can hear you. All better now?
Yeah, much better.
Okay,
so sorry.
sure.
It's
Not
a
a
throat
problem.
ache. Okay, so I was saying adenomyosis, it's a very important, disorder in the uterus that could lead to miscarriages. So of course, when talking about adenomyosis, we need to first inform the patient that there is special protocols to prepare uterus with the 3 months of agonist. So it's not in the same cycle that we can do ovarian stimulation and embryo transfer. We need to work first with stimulation, create embryos. Again, I recommend PGS, and then work with endometrium and only transfer after 3 months of the capeptyl of agonist. Of course, if there are other factors that could involve these problems of repeated miscarriage, we also need to work in parallel. So it's not to use prednisone as empiric treatment, it's only if necessary. So in that patient in particular, I would strongly recommend PGS and then work with endometrium preparation with 3 months of agonist, but also exclude other possible problems apart from adenomyosis.
Understood. Thank you so much for your advice. And as I mentioned, for your very first question. And let's have a look. There are more questions coming in right here. This one is from Emma. If I had a miscarriage after IVF with donor eggs, when should I start? Again, I'm 42. It was a month ago.
So sorry, Emma, for this. But of course, you need to be optimistic. You have implanted, so you're closer to your pregnancy. So I'm happy to inform you that this is not, a rare case. It's not that unlikely. So you need to continue working with your gynae, and you need to work again and transfer another embryo. If you have had curettage, you need to wait 3 months. But if it was natural miscarriage, then with 1 month, it's okay. With only one miscarriage, it's not necessary to study in the possible causes. Of course, you can do it, but it's not necessary. So I would suggest to see with your gynae the number of embryos that you still have, and if your gynae considers it could be problems, and decide together if you do any test before going ahead or if you just go ahead with another embryo transfer.
Thank you so much. And yes, Emma, fingers crossed for sure. Okay, we hope that all will be okay in the end. And let's have a look. Okay, there's another question that we have here from Denisa. It may be possible that the only viable embryo was the most developed one.
If you need, Denisa, to clarify something after my response, please feel free. So yes, always the most, developed, so the most expanded and the best in quality, usually it's, the most viable. By contrast, it's not only regarding morphology, the impact in genetics, so it's also the age. So morphology, it's very important, but also if you're having repeated miscarriages, I would say PGS before transferring. But of course, it's extremely important to study in your case if PGS is offering you an advantage or any disadvantages.
Perfect. Thank you so much. And there's one more question from Denisa. So let me go straight to this one. So with low reserve, you advise double stimulation?
It's a very good question, Denisa. So in low ovarian reserve, what I recommend is not to freeze embryos. What I strongly recommend is try to create embryos and if possible to transfer. By contrast, imagine I have a patient that she's young and she eventually would like to have more than one child. Then yes, I recommend to do double stimulation and try to freeze at least one embryo for the future. Because what happens if in that patient in particular, I achieve pregnancy and then she come back, imagine, with 39 or 40 years. If with 37, she has low ovarian reserve with 39 or 40, that will be still more difficult. So yes, this is always something that we can decide together if it is convenient or not.
Understood, of course. Again, thank you so much, Denisa. And if someone is typing, possibly it's Denisa, we will be able to go back to this. Okay, let's have a look. I'm not sure if it's Denisa. So let's have a look at the next question. Could you tell which tests compound the immunological investigation?
Yes, of course. So let me inform you that immunological, it's a very, big part of miscarriages problems and also with implantation failure. So we start with the KIR testing to be sure if you have abnormal KIR, which will be KIR AA, which means that you have more risk of miscarriage, and we need to see if we need immunological treatment for that. Then we also see natural killer cells to see if you have more risk to kind of attack your embryo with the natural killer cells. And again, we need to use prednisone. Also, we need to study celiac disease, thyroid problems, metabolism or of glucose and insulin, and any other autoimmunity that you could have to see if you need treatment to suppress that immune system.
All right. Thanks so much indeed, of course, for yet another question and your explanation. Okay, this is a question from Denisa, from our previous patient. It's about cost, so I'm not sure if you can help, Dr. Garcia. How much does it cost, the double stimulation? Are you able to tell us, more or less?
So it depends if we do PGS or not, okay, because we can offer double stimulation without PGS, so traditional IVF, or with PGS testing. I would say for traditional IVF, it would be around 8,000 euros, whereas for double stimulation with PGS, it would be around 12,000 euros. But I'm not 100% sure. Okay, it's always much better to contact our coordinators, Carolyn, because I'm always, working with medical staff.
Of course, that's understandable. So still thank you for providing us some details. And of course, as Dr. Garcia has mentioned, you can always get in touch with the team at Tambre, Clinica Tambre, and I'm sure they will be able to help you with the details as well, of course. Okay, let's have a look. More questions are coming in right here. Another one, it's a bit of a longer question. So let's get to that. At what point during IVF would you recommend treatment for thrombophilia to avoid future miscarriage? I am 41, have had a miscarriage at 8.5 weeks via natural pregnancy. Also, what chance do you think I have with 2 embryos grade 1 frozen when I was 40? The clinic I froze the embryos does not do PGS.
Okay, so thanks a lot, Christina, for your question. So thrombophilia, our medical evidence reports that we need to start studying these kind of problems when there is more than one miscarriage. But of course, we need to take into consideration other factors such as problems in your family with coagulation disorders, whatever. And also, if you have ever had any problem with coagulation and not only miscarriage. So I would say in your case in particular, it would be quite understandable to do thrombophilia study and see if you need to use heparin and or baby aspirin. But of course, it's always the most important, the age of the embryos. So as long as we don't know when you had your miscarriage, all miscarriages that are, when you are more than 38, the main cause, it's the age of the egg.
Okay, sorry. As you can see, Christina has added that I had it at the age of 38. Yeah.
Yeah. So at this point, Caroline, as long as she was 38 years old, it's not that likely to be because of thrombophilia, and it's more likely to be because of maternal age, okay? By contrast, as long as she has 2 embryos frozen, and probably she has no more, possibility to go ahead with other embryos, then I would say to exclude thrombophilia problems, and more if her dad had thrombophilia problems.
Okay, understood, of course. Thank you so much for that. Another advice, of course. Christina, if there is, okay, there's a thank you from her right here for you, Dr. Garcia, as you can see. Thanks so much indeed. And let's get going with the next question. I missed one, so let me just go back to this one. I would like to know if repeated biochemical pregnancies are considered a miscarriage.
Yeah, of course, repeated, biochemical miscarriages are considered also miscarriages. So it's different, and we need to, individualize and see if, again, the age of the egg was when you were like less than 38, or if you were 38 or more, and if it was after natural pregnancies or after, imagine, PGT tested embryos. But again, they are considered miscarriages.
Again, thank you for that question and of course for the explanation to this. Okay, and of course there's thanks from the patient. However, there is a follow-up, okay, from Denisa, from our previous patient. So if you can have a look at her comment also here. You said not to freeze in low reserve, but why, if there are studies that confirm that freezing makes them more resistant? Internet source.
Yeah, thanks, Denisa, for your question. So it is very easy to understand. It's not that freezing makes the embryos more resistant, because of course we are doing, more invasive procedures for your embryos. By contrast, the freeze-all studies suggest that because endometrium normally it's more receptive in a frozen embryo transfer compared to natural cycle after IVF. So the impact, the benefit, it's not because of the embryo. It's having, a more energetic, possibility or more resistant. It is because of the endometrium. So that's the reason why in low ovarian reserve, why it's always our objective to create at least one embryo, and it's a challenge because it's not that easy. We really need to individualize if it is convenient or not to freeze that embryos and be at risk of not thawing that embryo, because I remember my last patient having also repeated miscarriages. We did PGS, and we achieved to had with dual stimulation 3 euploid embryos. Of course, they were frozen. And when we had the embryo transfer, the day of the embryo transfer, the first embryo was not able to survive. So we did the thawing of the second embryo. So it means that we, create one embryo, but it was able to transfer because it didn't survive. So this is something that it is very important to understand. It's not improving your chances because the quality of the embryo, it's because of the endometrium.
Okay, thank you so much. Denisa, okay, thank you from Denisa here as well. Okay, excellent. Okay, no problem. Let's have a look at the next question. Just give me a second. Yeah, next one is right here. A bit of a longer question here. 39 women healthy, all test normal, not possible to PGS regulations. Immunology checkup not easily available in the country, pregnant via IUI and normal delivery 4 years ago, then multiple IUIs, IVF, fresh and frozen with donor sperm, pregnant in about 50% of cases, all early miscarriages, biochemicals. What to do? What more to check?
So I would say in that case, it is extremely important to exclude, genetic problems, okay? Because this is the main problem for all my patients. So when 39 years old, we should start doing karyotype, and if karyotype is normal, even though in your country it's not possible to do PGS, I would think about going abroad and trying to exclude embryos. For instance, I explain you that one of my last patients, just to have an idea, with 38 years old, she had 5 blastocysts with only 1 IVF cycle, but the 5 blastocysts were abnormal. So imagine if that is your case. The main cause, if you had a normal pregnancy, but right now you're having repeated miscarriages or not implantation, the main problem is, the quality of the egg. So I would strongly recommend, if you want to continue with IVF, doing PGS to be sure if your embryo is normal or not. Of course, you can think about doing, more immunological testing, exclusion of problems in your endometrium, but in medicine, the most frequent, it's what normally occurs. So more than 50% of problems of repeated miscarriages, it's because of PGS. And when we are concentrating with more than 38, it's more than this. And for the question, I think of the same, I don't know if it's the same, but it's related. If we can do PGS and transfer at the same cycle.
Okay, right.
It is possible, technically speaking, we can offer you the PGS on 24 hours demand.
Okay, thank you for the clarification, and thank you for your follow-up, of course, Denisa. Hope that helped. Yeah, okay. And of course, there's a thank you from the previous patient, from Natalia. Right here. Okay, there are like 3 questions left. We will be slowly finishing, but of course, if you have any questions more, go ahead, type those in, of course. And let's have a look at the next question. I haven't had miscarriage, only failed implantations. Apart from the embryo, would you do ERA right away or check for other things impacting implantation?
So I'm always very honest, Maria, with my patients. And if you have had different failures with good blastocysts, I would, study whatever it's possible before going ahead with other embryo transfers. So I would suggest ERA, EMMA, and ALICE test, so exclude problems with endometrium. Also study 3D scan or IRM or hysteroscopy to exclude problems with your uterus in terms of cavity, and also immunological and coagulation problems. And remember, if embryos were not tested for PGT, it's something you always need to, take into consideration for your next embryo transfers.
Excellent. Thanks so much for yet another explanation, of course. And the next question from Natalia. Okay. Would you recommend checking HLA compatibility in the couple if idiopathic secondary infertility? Could HY restrictions be an issue? First child was a boy, normal pregnancy, delivery, no other known issues.
So in your case, if you had a child, it is very unlikely that you have HLA incompatibility. Of course, I cannot say 0%, but it's extremely unlikely that HLA is the problem. So I would say to study in deep your ovarian reserve, to take into consideration the quality of sperm, and see if you need to do PGT testing or not. And if PGT reveals that you don't have normal embryo, then you could know the reason why. And if you only have, for instance, one normal embryo, one euploid embryo, I would suggest to study whatever it's possible to maximize the possibility of implantation.
Once again, understood perfectly. Thanks so much. Okay, Maria has added one more question. One embryo tested in NGS, one with fish. How big is a risk that the embryo comes back normal with these tests? Is actually aneuploid, as it doesn't check all chromosomes.
So I'm not sure if I can understand the question, Caroline. So I understand she had one embryo tested from next generation sequencing, and another one with fish, which is a different technique for chromosome studies, which is, it is not right now done. How big is a risk that the embryo comes back normal with this test?
Which
I don't know if she's referring that if the embryo is a neuploid embryo, if there is still chances that the embryo is normal.
Possibly, Maria, if that's correct, just please. Yeah, okay. There is a follow-up. Let me go straight to that. Fish only checks 8 chromosomes, NGS 32, but I know it's not 100% sure that they really are euploid. Okay.
Yeah, so NGS, it's studying the 23 chromosomes, and fish depends on the number of groups, so normally 5 or 8. So again, we cannot say 100% with 4 or 5 cells that we will study from the blastocyst that the embryo is 100% euploid. So in the PGT carried out on day 5 or day 6, we study in the external part called trophectoderm the karyotype of that embryo in particular. And we have euploid embryos. On the other part, we have aneuploid embryos, and then we have mosaics. But of course, this is the result of that 5 cells, and we cannot say 100% sure if this is euploid or not. I understand what that patient is suggesting, but the accuracy of this test is extremely high. So I would say you just need to, rely on especially next generation sequencing, as long it's a very efficacy testing.
All right. Thank you for the clarification, of course. And Maria, thank you for the follow-up as well here. Okay. Yes, Maria said thank you, of course. And Denisa, one more question. If I had a miscarriage with trisomy, can it be a problem with compatibility?
No, it's nothing to do with compatibility. Trisomy is a problem regarding normally. If it is trisomy normally, it's because of maternal age. So it's nothing to do with compatibility.
Okay, and thank you for the clarification once more. And I'm just waiting, okay, because that looks that it might have been our final question. However, someone is typing, so let's just give it a second and let's have a look if we have another question. I want to make sure that you received all the answers. So if you have any left, you know what to do. But already I would say this is an interesting session, lots of questions, lots of details as well. And let's have a look. Maria has added one more question. Do you offer ERA in your clinic? And if so, how quickly do you get results?
Thank you, Maria. Yes, we're offering and doing very often this test, and it takes normally 2 weeks for the results.
Excellent. Thanks so much for another question, and of course for your help with this. And yes, I guess we will be finishing for tonight. So everyone, thanks a lot for being active participants here tonight. It's been a very interesting session, and I do believe that now you received some answers that you were looking for. And well, Dr. Laura, as always, it's a pleasure to have you here. I'm glad that you are back with us, and thank you for your time. Of course, it's always amazing to listen to how you help your patients. Always so passionate as well about it. So, thanks so much indeed. And before we finish, anything else you would like to add?
Thank you so much, Caroline. It's always a pleasure to work with you, to have online webinars, and to eventually help, other patients living abroad and having problems to have their babies. So we are happy to always help them and give, other approaches.
Any way we can, right? Even with those webinars, I always think that it's always something that we can do. So thanks so much indeed. And okay, someone from Spain is also here. So great to have you here. And of course, I just want to mention there are some Spanish webinars already with us. I mean, myivavances.es. So if you haven't seen them, there will be one on Wednesday as well. So you can join us as well in Spanish now. And yes, with that, let's finish for tonight. Just remember, it has been recorded. You will have a chance to, of course, have a look at it once again if needed. You will find it on myivavances.com, but also on our YouTube channel. And we will be back with some more events. And we will be back actually this Thursday. There is another webinar. We will talk about low ovarian reserve, of course, about success stories. So you can join us, have a look at it. And Dr. Laura, a pleasure as always. As you can see, another thank you is coming up right here. Important information, all interesting. So thanks so much for that comment as well. And well, everyone, have a lovely evening. Take care. And I do hope to see you here on Thursday. And of course, Dr. Garcia, I know there are some more webinars and there is one upcoming with you. Don't remember when exactly, to be fair, but I'm already looking forward to it as always. Thanks so much. Take care.
Thanks a lot. Bye
Bye.
bye.